Orbital region basically comprises of the different bones that constitute this particular region. It is the frontal bone, then we have the maxillary bone, then we have the temporal bone, then we have parts of the ethmoid and the sphenoidal bone that is basically making this orbital cavity, and it is retaining the orbit, or it is retaining the eyeball itself. So any trauma that can occur to this orbital region can basically result in a very devastating kind of a condition for the patient itself. It can be due to the bony structures that are present over here, and then we have the eyeball that is basically a soft tissue and that can be damaged, that is responsible for the vision of the person. So it can basically result in the complete blindness of an individual. Then we have the nerve damage, we have the muscular damage, which can basically clinically manifest as the extraocular movements which are deviated, the squinting or the strabismus phenomena, or the amblyopia, which can be examined or observed in a particular person. So there is a range of orbital trauma that can occur to this the bony framework of this orbit, that is basically comprising of the frontal bone. Mostly the roof of the orbit is formed by the frontal bone. Then we have the zygomatic arches of the frontal bone that are constituting the medial and the lateral walls. Then we have the sphenoid bone that is somewhat constituting the medial wall, and then we have the zygomatic bone that is majorly constituting the floor of the orbit. So all of these bones can be fractured whenever we have a trauma to this orbital cavity. Orbital cavity can be visualized as a conical or a pyramidal shaped cavity. A lot of nerves are passing through the superior orbital fissure and the inferior orbital fissure that are basically located in the cone of the this pyramidal shaped cavity. So any damaged or any fracture that can occur to these orbital bones, or the bones that are basically constituting the orbital cavity, can result in a nerve damage. The optic nerve itself can be damaged. The trochlear nerve is at stake over here. That is basically the third and the fourth cranial nerves that are passing through this cavity, and that can be damaged over here. So it can be a very vast situation. The clinical pictures can vary from person to person depending upon the kind and the intensity of the impact or the mechanism of injury. So we'll be basically evaluating the patient first of all, whether he or she is suffering from some other life-threatening condition or some other life-threatening injury, if he or she is suffering from multiple injuries at the same time. So we'll be dealing, or we'll be stabilizing the patient first of all. That is, stabilizing the patient would include maintaining the airway, breathing and circulation, and stabilizing the patient on whole. And then we'll be moving on to the severity of the injuries one by one, and the most life-threatening injuries will be treated first of all, and then moving on to the orbital injuries or the orbital fractures itself. And the repair procedures, they again depend upon the type of injury and the type of fracture that has occurred in this particular kind of patient. So over here, there are different types of orbital fractures that we'll be studying in this particular section. It can be just a hairline fracture. It can be a fracture that is depressed. It can be a fracture that is displaced. So all these kinds of fractures, depending upon the intensity of the impact, we can see in a single patient or in multiple patients over there. So first of all, one should know the normal anatomical structures or the normal anatomy of the orbit. As I've already emphasized, it's a conical shaped cavity, and it has a base, it has an apex, and then we have the medial and the lateral walls, we have the roof and the floor as well. So all of these anatomical structures we should maintain. We should know the bones that are participating in the formation of this orbital cavity as well over here. And then we'll be moving on to the evaluation of such patients in whom we are suspecting the orbital fractures. So first of all, the saving the life, or first of all, treating the most life-threatening conditions in a patient would be the criteria that we would be following in a particular patient. And then we'll be moving on to the blowout fractures. So the most common fractures that we encounter over here are the blowout fractures, in which there is an increased intensity of the impact, and basically it has its particular signs over here. What are these particular signs or the clinical features that are observed in these blowout fractures, and the complications along with the treatment guidelines of these blowout fractures would be discussed over here in this very first section, that is particularly dealing with the types of the orbital fracture. So as we were already concising this fact that orbit is basically a pyramidal shaped cavity, as you can see over here, it can be any object that is basically having an impact with this orbital cavity. And then we have an eyeball structure over here. We have the bony structures that are surrounding this eyeball structure and providing basically a protective layer to it. So one should know that what intensity of impact was there, what kind of a weapon was used for it, whether it was a blunt object, whether it was a sharp object. We can classify them according to the type of objects that are causing this particular kind of injury in the patient. The classification can be also on the basis of open or closed, whether it is a closed trauma, not any lacerations. Any lacerations, incisions, or any perforating and penetrating injuries are a part of the open traumatology. And then we have the closed trauma, in which we have bruises, we have contusions, and we have internal hemorrhages occurring due to this closed trauma. On the other hand, we have the internal kind of damage, that is to the orbital skeleton, to the rim of the orbit, and the most complex kind of damage or trauma that can occur over here is the damage that is occurring towards the internal structures, even to the structures of the brain. The nerves can be damaged. As I've already emphasized, the third, fourth, fifth cranial nerves are passing through this area, and they can be damaged right here. The rim can be damaged of the orbital cavity over here. So this is a picture in which we are seeing or looking at a patient of orbital trauma in which we are observing strabismus or squinting phenomena. There are multiple reasons to it. Most of it are the nerve damage that is basically causing the squinting or strabismus in this kind of patient. The orbital fractures can be the blowout fractures on one hand that are basically typically 10 to 15 millimeters behind the rim and just medial infraorbital canal. So they are medial to the infraorbital canal, and one should know that these are known as the blowout fractures. On the other hand, we have the tripod fractures. The disruption of the zygoma is very important at ZNF and Z and M sutures and along the arch. So this is the tripod fracture in which the zygomatic arch is also involved along with the floor of the orbital cavity, which are basically forming a tripod in this way. We have an ophthalmos, which is a part of the tripod fractures. And on the other hand, we have the malar flattening, which is one of the other clinical features that can be observed over here. We have the inferior lateral canthus displacement. So these are the particular features from which we can diagnose whether it is a kind of a blowout fracture or whether it is a kind of a tripod fracture. That the tripod fracture, the mainstay over here, that it is also involving the zygomatic arch in that particular patient or in that particular person whom we're talking about. Then the evaluation of the orbit is very important. We're going to start evaluating the patient by inspecting the eyelids first of all. The telecanthus is very important, and then the tendon disruption or the nasoethmoidal fracture over here can be the most disturbing situation, in which we are also fracturing the nasoethmoidal bone, and that is also going to be displaced in particular cases, and it has its own complications over here. So all of this evaluation is again very important over here. Whenever the eyelids, we are examining the eyelids, we're going to look at any globe displacement or any proptosis. Proptosis is basically the exophthalmos, or the protrusion of the eyelid. That is usually, you would see these patients in thyrotoxicosis, a lot of patients would present with proptosis. So we'd start inspecting the case right from the eyelids, and then we move on to the motility, that is the ductions, and the diplopia is basically the double vision. And we're going to include the fluorescein staining over here. The pupils are then examined in this particular patient. APDs are performed, efferent pathways are checked, and then we move on to the mydriasis phenomena in this particular patient. To palpate, it's very important that we palpate the whole rim. If there is any discontinuity, or if there is any disruption, that is going to suggest that the patient has some sort of a displaced fracture or not. Crepitus is very important, and then the retropulsion. So during palpation, you're going to look for any disruption in the rim, then you're going to look for crepitus and the retropulsion. Nerves are usually the first and the second branches of the trigeminal nerve. The trigeminal nerve, when we look at it, it's basically having these three branches, that is the ophthalmic, the mandibular, and the maxillary division. Over here, we're going to check the ophthalmic and the maxillary division. That is basically in the involvement in the orbital cavity. So all of these nerves has to be checked, and this is the whole complete evaluation regarding the patient of blowout fractures. The signs of the blowout fracture would include the periocular ecchymosis, and then we have an edematous appearance that is basically surrounding. Even you can see over here that there is a periocular ecchymosis. This discoloration is very important, and then this swelling is very important, which is very obvious over here. So all of this bluish discoloration, this bruising phenomena, and this swelling phenomena is observed in blowout fractures. Infraorbital nerve anesthesia is usually seen in such patients. Then we have the ophthalmoplegia, typically in up and down gaze, double diplopia. So usually the patient would give you a history whenever you ask him to look up or look down. He's going to give you the complaints of double vision or double diplopia in this person. Then we have the anophthalmos, and if it's very severe, it's a severe kind of a blowout fracture, we're gonna see this anophthalmos kind of a condition over here. The imaging would include CT scans. So on CT scans, you're going to observe the axial and the coronal views as well. 3 millimeter sections, 1.5 through the apex, and if suspect, you're going to perform this TON over here as well. So these imaging techniques are very important, and we are going to perform the MRIs as well. No good bone metal foreign bodies can be detected through this phenomenon of MRI. Subdural optic nerve hematomas. So optic nerve can be involved at this level, and then we have the hematomas that can be involved at this level. So this is the kind of imaging techniques that we're going to use in particular cases of blowout fractures, including the CT scans, MRIs, X-rays obviously included, but these are the advanced techniques that can be used in this particular patient over here. The investigations would also include the restriction of the right up gaze and then the down gaze, because that is going to complicate the situation due to the diplopia. Secondary overreaction of the left eye is very important. Surgical treatments are usually devised for these kind of blowout fractures. We have these, basically the zygomatic bone is involved, the floors are involved in a lot of cases. So the surgical treatment would include the subciliary incision, first of all, as shown in the very first picture over here. It's basically showing the subciliary incision. That's basically quite a neat incision. Again, it's going to be a very minute surgery, a very delicate surgery that has to be performed. Periosteum is elevated. It's shown in this second step over here, diagrammatically represented. where we are basically elevating the periosteum, and then the entrapped orbital contents are freed over here. It can be any exudates, it can be the blood that is entrapped along with the orbital contents. So we're going to basically entrap the orbital contents and we're going to free them over here. Then the defect is repaired accordingly. Again, the defect has to be repaired in layers because that is going to affect the overall reconstructive surgery in any particular case of the eyelid surgery or any particular case of the orbital surgery over here. The periosteum is stitched back in layers over here. Talking about the zygoma tripod fractures, as we've already talked about them, as you can see in this picture, the zygomatic arch is involved over here along with the floor and the lateral walls in a lot of cases. Because this frontal processes of the zygomatic arches, and then we have the zygomatic processes of the frontal bone, they are basically forming the lateral walls of the orbit over here. And any fractures that are basically including the lateral walls of the orbit, that is shown over here, and then the zygomatic arch that is shown over here. So that is basically going to be represented as a tripod fracture, and as we can see, it's making this tripod feature over here. That's why it's called the tripod fracture. Tripod fractures consist of fractures through zygomatic arch, then we have the zygomatico-frontal sutures, and then we have the inferior orbital rim and floor. So this is the complete definition. Any fracture that would include the zygomatic arch, the zygomatico-frontal sutures, along with that the inferior orbital rim and the floor, they are going to be termed as the tripod fractures or the zygoma tripod fractures in this particular case. The radiographic imaging in this particular case of the zygoma tripod fractures would include the Waters view, the submental, and then we have the Caldwell's view. Waters view is this particular view in which we're also looking at these sinuses and looking at any fractures that are surrounding these structures as well. So it's again very important to look at the frontal sinuses, to look at the maxillary sinuses, and the walls can be damaged in any case. So radiographic imaging is very important over here. The coronal CTs of the facial bones are very important. That is going to basically include the 3D reconstruction in this particular case. The clinical features of this tripod fractures would include the periorbital edema and the ecchymosis. In this particular case, you can see this is a case of ecchymosis as well as severe periorbital edema in this particular case. So if it's a very severe picture, always think of or always suspect that it can be a tripod fracture as well. Hyposthesias of the infraorbital nerve, they are again one of the complications that is seen in this particular case, and then the palpation may reveal these steps. So if we palpate this tripod structure, that is the zygomatic arch has to be palpated, and then mostly the laterals and the floor of the orbit is palpated, you would know, or you would just find out that there is some sort of a discontinuation that is figuring out or that is pointing out towards any sort of a displaced fracture in this particular case. Concomitant globe injuries are very common over here. So over here in this particular section, we basically divided or we categorized the orbital fractures. Can be the blowout fractures on one hand, in which we just see that there is some sort of a displaced fracture in the lateral medial walls of the orbit, the roof or the floor of the orbit. On the other hand, we have the tripod zygomatic fractures in which the zygomatic arch is also involved with the lateral walls or with the roof of the orbit. So these are the different types of the orbital fractures that we have discussed over here. So that is the end of this section. Thank you for watching sqadia.com.